Today's guest is Jim Lavalle. He is a internationally recognized pharmacist and also a naturopath, an ND. He is also a board certified clinical nutritionist and an internationally recognized expert in peptides, which, as you see, we will discuss on how some of them are medications and some of them are not. We get into the high level view of what a peptide is, and we discuss some of the things that we wish the general public would know. He does teach frequently for A4M, and he also has several different businesses. He has the Metabolic Code, but most recently this year, he was appointed Chief Science Officer of Lifetime Fitness, where I happen to go to the gym. So hopefully you can learn a lot about peptides. We tried to talk at an average level during this podcast. The video might not be the very best for this one, but I think that the content is good. We've mentioned that we want to have more guests, and we have an excellent one today that we've been very excited to discuss a variety of different topics. Please welcome Jim Lavalle. Thank you for joining us.
Great to be here.
Yeah. So you're obviously known for a lot of different various things, but I guess for better or for worse, some of the videos that we do that do the best have to do with peptides, metabolic health, and lifestyle. And those are kind of some of the things that you're very well known for. But I guess in your own words, what do you feel like you're most well known for, and what are you most excited about lately?
Yeah, it's a great question. I mean, I guess I'm so excited about the whole category of how we get people to age better. So whether you're looking at kind of how do we take someone that's not well and start to move them towards a path of becoming well or being in homeostasis? And then how do I take a high performer, whether it's special forces, professional football players, basketball, hockey, you name it, have been around all of them. And how do we keep them from eroding from their performance because they were excellent at the beginning and then under duration they create problems? So I look at things like peptides as tools. So I've written 5 databases, right? I've written databases on herbs, nutrients, herb-drug interaction, drug-induced microbiome, drug-induced nutrient depletions. Those are all kind of tactics and tools, right? But in the end, I like to think we look at a whole body approach to someone's metabolism, realizing that you're only as strong as the weakest link. So if everything's great, but your kidneys are filtering poorly, everything's not so great, right? So I would say that, in my role as Chief Science Officer at Lifetime, for example, it's really trying to create organization and thoughtfulness to programs that people are being put on, and also educating practitioners, through my role with the American Academy of Anti-Aging Medicine, is creating that same sort of logical approach to how you get people well. So that's what gets me excited.
I love that. And your background as a clinical pharmacist certainly helps in that, because at the end of the day, a lot of things are just pharmacodynamics and pharmacokinetics. That's just the drugs or the molecules' effect on the body and the body's effect on the molecule itself. So you mentioned your role in Lifetime Fitness. As you may or may not go, I go to Lifetime Fitness, and we actually have a corporate account or whatnot. So a lot of us go there and
cool.
Improve our metabolic health, prevent future doctor bills. But yeah, I know they have competitions from time to time where you do various things and transformations and you can win prizes. But I've noted that I suppose Lifetime is also more interested in peptides. I don't know how influential or how much you can talk about your role there, your plans.
Glad to talk about it, man.
Yeah. But I guess how's that come up? And, I see places like Weight Watchers and Hims and Hers and these other places that you wouldn't think would get into more of like clinical practice. Vitamin Shop having TRT now.
Yeah. That was crazy, right?
Yes.
I couldn't believe that one. I was like, wow, going into the Vitamin Shop and getting your GLP-1. Okay. So I mean, with Lifetime, I think it was a logical extension. We're hiring medical directors, we're hiring nurse practitioners, we have dietitians and great fitness performance coaches on board already, as well as mindfulness and, that whole aspect of healthy way of life, right? This is just an extension. I think it was really forward facing when I only been there 6 months, but obviously with my role, you know, in the International Peptide Society and being the chair of that, and writing a book on it. I mean, and I've done work with them in the past. They were like, "Hey, this is what we're planning on doing," and I said, "Well, that's great, but if you don't have an integrative approach of how to use a peptide, so whether you're talking about using sermorelin or talking about using a GLP-1 like a semaglutide or tirzepatide, or how are you going to use it for the good of the person, right? Because there's a lot of folks that are just injecting GLP-1s and, hey, wow, I lost weight, but typically they're going to be dependent on that. If they're not taught a different way to eat, they're not taught a different way to think, meaning that,
Yes.
when you talked about molecules and molecular signaling, emotions do that, right? Molecules of emotions, right? So it's got to be mindset. It's got to be what you're eating and how you're doing that's right for you, for the amount of workload that you're doing, what your goals are. And then it has to be what nutrients you should be taking, how much exercise you're doing, right? Creating an active lifestyle, but maybe also realizing that depending on the age of the individual, what is that level of activity that's appropriate for them? And then it's really following lab tests to make sure that they are optimizing and not just, injecting a drug thinking that that's going to be the next miracle. We all lived through this with the HCG diets, right? I mean, my medical students when I was teaching at University of Cincinnati. I had fourth year med students and pharmacy students in their fifth year. We did a white paper on HCG. And while it's interesting that people would lose weight on it, they would still rebound. They would have to come back and do it again, where they're on a minimally caloric diet. You end up losing a little less lean mass, but in the end, you still lose lean mass. And losing lean mass is the enemy of aging gracefully. So what we're doing is measuring lean mass, making sure that they're on a diet that, if you look at the last study that just published a few weeks ago, 1.2 to 1.6 grams of protein per kilogram to reduce lean mass loss, combined with weight training, combined with teaching responsible eating. So that's kind of the way we approach it with Lifetime, is a much more, I would say, concentrated effort. It's staying within our ethos or philosophy of a healthy way of life.
That's excellent. Yeah, I love that. I've noted, and it's good that larger companies are becoming more and more open to integrative approaches other than just what they're specialized in. Because if you go to an obesity medicine clinic, then exercise is probably the most difficult component to get people to add in. Whereas if you go somewhere else, then perhaps it's something else, because people have these visceral responses. And I'm curious of how you approach this. As you mention, if they're for or against peptides, and they say, well, no, I'm not for peptides like synapsin, which of course is not really a peptide, or
Not at
tesofensine,
all.
which is definitely
Right.
not a peptide.
Right.
Tesofensine's not. And then they're for insulin, which is a peptide.
That's my argument all the time. I said, I just had to respond to someone who was actually anti-peptide, but synapsin, which is a ginsenoside, right? It's just ginsenoside R3. And then you've got, RB1, so you've got, the synapsin pro. But I said to this person, well, are you against someone taking insulin? And they were like, well, no, because insulin is life-saving. What I think GLP-1s are, I also think they're life-saving, but more in a chronic situation, not an acute situation. Insulin's pretty acute. If you're a type 1 diabetic, you don't get insulin, you can be in pretty big trouble pretty quick. I think the GLP-1s are re-regulating incretin hormones because people have become overweight, and due to stress or environmental burden or improper eating or never going into autophagy, not enough sleep, whatever we want to call it, right? All those root causes, you end up triggering unopposed glucagon. And managing glucagon is every bit as important as managing insulin. It's just important for a different reason.
Yeah.
Glucagon is important because if you don't manage that, you will be fat. You will have a problem getting to your weight loss goals. And so we've seen this. People, they diet, they do exactly what you say. They exercise, they do exactly what you say, and they don't lose a pound. And then you turn on that incretin hormone, and now all of a sudden they're losing weight. But I think it's like it's a gift and it can be potentially very dangerous at the same time when people just rely on it because they're going to lose 30 to 40% of their lean mass when they just use a GLP-1. If they do not incorporate other things like sermorelin, creatine, HMB, at weight bearing, better diet choices, and all those things are important.
Yeah. Correct dose. As with
Oh,
anything, dose makes the
oh,
poison.
well, all man, you bring up such a, I mean, you're spot on because all the real adverse events on these GLP-1s are related to dosing. And that's the other thing I failed to mention. What we're doing with it at Lifetime is that we're titrating the dose to the minimum dose where they lose weight. So many times we're at a fifth to an eighth of the typical, say, brand dosing. And what that allows us to do is as people have lost their weight and you're reverse titrating them out, you're getting them off. Well, they're not as dependent, right? You haven't overwhelmed those receptors. To your point earlier about molecules and receptors. I mean, when you just bang on those receptors really hard by an excessive amount of drug, when you take that drug away, that receptor is going to say, "Where's my drug?" It's like those little receptors become junkies for it, right? Whereas if you're trying to
Yeah.
retrain that receptor in order to become awake again, that's a different homeostatic process.
Yeah. Oh, that's a good point. I've noted that a lot of other companies have kind of been riding this line of do they want to do all brand name GLP-1s? They want to do compounded GLP-1s. And
Right.
I did note that this week, Weight Watchers had a huge bump in their stock price after they announced that they're going to now go back to doing compounded GLP-1s. So they acquired a company and then basically aren't going to go with it anymore because they had quite a bit of struggles. So, I mean, it almost seems like that is going to be standard of care regardless of what happens. So it's great that there's individuals that are talking about correct dosing because a lot of individuals that are using these are not diabetic. For example, I think, was it Brian Johnson, the Blueprint guy, uses it for cognitive reasons. I don't know if you follow him, but
Unfortunately.
yeah, I mean, and I'm not against him. I love that he posts everything that he does publicly. He's very truthful and honest.
Yeah,
So that is
agreed.
fantastic. But it's no different than a bodybuilder. He's more of a health builder. Bodybuilders will push the doses on things and try experimental things. And I think as long as you have informed consent and you do it with your body, I think it's reasonable. I don't know.
Sure. I'm
Yeah.
not against, look, I think in the end, I believe in personal freedom as long as you're not harming yourself. I mean, I think if you want to try and push the envelope of using 8 milligrams of rapamycin versus 3 to 5 milligrams of rapamycin for your senescence, okay, that's you. But I think with the compounding side, because I mean, I've lectured for the Professional Compounding Centers of America for a long time. I'm a huge proponent to compounding because you're right on. I mean, you as a physician should have the right to adjust a dose to what you think your patient needs and not just what the drug company says a mass population of studies that does have a percentage of side effects related to those dosings, what they think you should do. I mean, in the end, you're in charge of that patient. And so I think that's important. And I do think because people aren't diabetic, I have a sister-in-law right now. She was using compounded tirzepatide. She found out she could get Manjaro on her insurance. So she moved to Manjaro. She was doing great on the compounded tirzepatide with less dosing on that compounded tirzepatide, right? She goes to Manjaro, does the full dose as recommended. 45 blood sugar drops out, almost passes out. so I think, and I'm not against in any way, shape, or form against the big drug manufacturers. Look, they create a lot of things that save people's lives, right? They're the ones that invented these compounds. I get it. I get their value, but there is a rule. There is a space for compounding pharmacy, and that's customization. That's why it's in the federal statute. I mean, I'm going to talk with FDA on peptides actually October 29th. So, I think it's important that healthcare providers are allowed that right to create individual needs of that patient.
Yeah, well, that's excellent. Thank you for your advocacy. On the topic of customization, one of the most common questions that I get, often from Zoomers, which is Gen Z, for those that don't know, they'll come up to me, in
That'd
the
be
Lifetime
me.
locker room, and they'll say, "Hey, what is, I saw your TikTok. What's the best peptide for muscle growth?" So I don't know. It's just such a loaded question.
Yes, it is. Well, I think there's a couple of interesting things coming out. One that's going to be coming out shortly that actually isn't a peptide, it's a small molecule, but I think it's going to be a monster, is OSO1. It regulates mTOR1, mTOR2, and upregulates AMP kinase. So you get this fat burning and muscle building effect. From the, when another one that was very popular, not a peptide, but categorized as one, ibutamoren, which was put on the category 2 list, which meant you're not allowed to compound it anymore, but ibutamoren or MK677, really good at putting on lean mass. I liked it in the geriatric population as well as in the young population wanting to build mass. Just, people get old and they, like me, you're in your 60s, you get a little cachexic and you're losing a little bit of that muscle. You get a little bit of sarcopenia, and that's part of aging, but I'm sure fighting against it. So I think that ibutamoren was interesting. I think, look, sermorelin is the one secretagogue that we currently can do from the compounding pharmacy perspective. If you go out past that, the ones that were available in the past but are now considered biologics, testosterone was phenomenal because it combined kind of IGF-1 signaling and enhanced muscle synthesis. So testosterone for me was, man, I really hated when that one got off the market. ACE31, new one coming out that is going to be good for building muscle. People are talking about using SLUPP32, but I don't know. It's a estrogen modifier, and I always worry about those in terms of, hey, for a male using that over time. So I'm not as convinced on that one yet, and no human trials. So that's kind of my very
Yeah,
quick rundown.
that's
But
a very reasonable approach. I like that.
yeah,
Yeah. Another thing I noted is, you've of course have a background in pharmacy and naturopathic medicine as well, but there's this dichotomy of big pharma versus what I call big functional, which is great that functional medicine is this big, but you have big pharma and small pharma, and as you have also listed disclosures that you've consulted or received money from those, which is good because it feeds your family and furthers your career. I
of
do too.
course, of
Um,
course.
but there's big pharma, big functional, or big supplement, whatever you want to call it, and then small pharma and small supplement. Um, how do you see the progression of big functional growing, and how do you, I guess, account for those potential subconscious biases that might come up? And obviously, they have to be focused on profit, otherwise they wouldn't stay in business.
There's so many. That is a very rich question. So I would say, meaning there's a lot of texture to it, a lot of layers. First of all, it's already happening. You got Nestle Corporation buying up over 30 nutrient companies over the last several years, right? So big pharma's already in it. I mean, I've consulted for Bayer, P&G, Thorn Research. I did their athletic line, helped kind of initiate and innovate on that. So I mean, I've been on all sides of this industry. I think there's a convergence that's taking place. And I think where the variation in the convergence is on the level of excellence that you're willing to reach for say the big functional. As there's companies that put together a good product, meaning the ingredients are good, but maybe there's not enough of the ingredient in there for it to really make a difference. So it's really what I call great window dressing. And therefore, people see the name, they think it's going to work, they buy it. Or you got to take 6 or 8 capsules, and that's great. What I'm most passionate about is the avoidance of adulterants and truthfulness in labeling, right? Where are there issues related to the purity of the product? And I'm not here to like tell people, oh God, you have to formulate a certain way. We all know that things like Ayurvedic medicine, traditional Chinese medicine, if you're looking at TCM, they have ways of combining herbs that are 5,000 years old that have shown over the years to have benefits. So I'm not in any way judging that. I just think that in general, if you look at where pharma is at least verbally going, is more towards acceptance of this concept of whole person health. It's what the NIH is talking about. And of course, they're going to want patented compounds to do it. Hence the failure of resveratrol once it got taken into the market, into the pharma side, and then they tried to bend the molecule and it didn't work, right? So I think there's a convergence that's taking place. At the same time, there's always going to be a barrier. There's that barrier of, what we need to do acutely, which it's a natural barrier, right? Someone comes in and they have an 800 calcium score, and their lipid particle size is 2,700, and their apolipoprotein B is 180. Well, you know what? A low dose Crestor every other day may not be a bad idea to get them under control while they're learning about how they're going to get well again, if they're even motivated to change. So you've got people that aren't motivated, like you and I've got a feeling that we're both Spartans. I mean, if I come to you and ask you what I should do, you're going to tell me 10 things to do. I'm going to ask you, how come not 12? I want 12, doc. I can do 10 all day long, right? Because
Yeah.
I'm wired that way. A lot of people aren't. So I think there's a natural barrier between acute care and disease state management that's always going to be there for people that aren't ready or aren't willing to take care of themselves. And then there is health optimization, prevention, looking at the epigenome, looking at multi-omics, understanding what you do to improve your longevity, and being passionate about embracing that and developing something for yourself that you're motivated for.
Yeah.
Some people just want nachos and chicken wings, man, and they're not going to change that. And
Yeah.
I kind of like them too once in a while, but my issue with that is I don't want us to get to the point. Ever seen the movie Demolition Man with
Yeah.
Sylvester Stallone? Where
Yep.
everything is like okay, oh yeah, you're only allowed this and you're only allowed that societally, right? I think
It's individualized.
it's individualized, and I think that's where big pharma, small pharma, big nutrient, small nutrient innovation comes from those small innovative thinkers at the base of that, and it filters up into both big functional health and big traditional medicine. Long
Yeah.
answer, I know, but yes, boy, that was a big question you asked me.
Yeah.
So
Uh, Shorter question this time. Related to that, one of the big barrier is pharmacy benefits managers, or PBMs. For those who don't know, they're basically the middleman between the pharmaceutical company
right,
and the patient, and they
correct.
determine what the prices are. So if you're not being particularly nice, you can call them something like the mafia, or they're pharmacy benefits managers.
I'm Italian, man. Mommy is not a bad word. When you're
Yeah,
Italian,
so they're the middleman. So they
sure.
definitely increase cost both from the pharma side and the patient side. How do we get rid of those? Or do you think we should get rid of those? I think we should. And if so, how do we do that?
Well, I think there's a lot of layers in healthcare costs, right? I think we really need to start to rethink health, right? And I think the more you create those kind of impediments, because it just doesn't affect pricing strategy, it affects therapeutic strategy,
Yep.
right? Because certain costs that you can't do because of that middleman. Now you could do if it was removed, the person might be able to afford it, right?
Mhm.
So it's creating a
It's
therapeutic strategy barrier as well as a financial one. And so I think that while there's administrative needs, I think one of the biggest things, and I've worked at this, my gosh, for a while, is what people are really looking for is proof that what we do matters. And I think when we can prove what we do matters, I mean, you and I are passionate about the whole person, diet, exercise, emotional well-being, physical, right? Where's their fascia at? All these aspects to their health. But what we haven't done a good job of, and pharma hasn't done a good job of this, nobody's done a good job of it, is, we don't even know if I name any 3 drugs that people take. There's no studies that show what they are together in the body. And that was kind of one of the passions of when I developed Metabolic Code was how do we start to say, what drugs are you on? What nutrients are you taking? How much caffeine do you take? How do you exercise? What's your diet? What nutrients? And then how well do you follow that plan? And then what's your outcome? Right? Because if we're going to be effective, I think at creating more direct programming, which I think the industry should have, right? I mean, people should be able to take direction on how to eat and exercise fairly easily, right? With an app and maybe a person guiding them, or at least, a clone,
Yeah. This is
right?
one thing that CrossFit does well is they say the continuum of health is sickness and then lack of sickness and then fitness. So you mentioned
Yes.
you want to do at least a dozen things to get you from lack of pathology over to fitness, which I really like that analogy. But I guess if you're willing to do a dozen things, the metrics that you want to track, and I don't know if you want to share what metrics or blood work or things that you track or peak and trough rapamycin levels, but they are different for everyone.
Yeah, they kind of are. Like if you look at, I think glucose is pretty simple. I think insulin is pretty simple. I think mean platelet volume, it's a great marker for metabolic inflammation. I think that, obviously homocysteine and C-reactive protein in some instances are really good. Obviously, if you get more complex into the complement immune system and you're looking at metalloproteinases and anti-cardiolipin antibodies or melanocyte stimulating hormone, which obviously peptides can affect melanocyte stimulating hormone,
Mhm.
awesome. But I think on a baseline, kidney function. Look, in the end, when people were really going downhill, they're going downhill because they're insulin resistant and their glucoses are an issue. Their kidney function is waning because of a loss of redox poise. So when you got an acidotic urine pH, by default you have excess hydrogen ion concentration, and that means you're creating more free radical damage. And there's great studies to support that. So people are dying because of heart disease. They're dying early because of diabetes. They're walking into dialysis centers because their kidneys fail too early. And so those are the first determinants for me. And then, if we want to go up from that and obviously look at, well, where's their cortisol? Where's their thyroid function? What is their lipid particle sizes look like? Where are their sex hormones at? Next tier. Next tier is, oh, okay, what's your leukocyte telomere length? What's your DNA methylation look like, right? We can move up that range. And then the strategy of why those things are broken are things like testing for SIRS, testing for metals, pesticides, bugs in the gut that are dysbiotic. So there's the tactics, but I'm a big believer that we don't even do a good job of looking at red blood cell magnesium versus serum magnesium. We don't do a really good job of counseling people on a 10 insulin and why that's a problem. And we don't do a good job of showing people that once they have a blood sugar of 95, they're at a 60% risk of being a diabetic in the next decade. Societally, we do in our space, I think,
Mhm.
most of the time. But I got to tell you, when I'm lecturing at A4M, I ask doctors how many people know your blood sugars and insulins. Not everybody in the audience raises their hand. And nobody does their morning and night blood pressures, so they don't understand whether they're a dipper or non-dipper. Are you under sympathetic tone? So a non-blood marker, things like HRV, heart rate variability is super
Yeah.
important.
Yeah,
right?
that's a good point. And I think most people in the health optimization space are familiar that HRV and resting heart rate are pretty accurate on almost all biometric data trackers, but deep sleep and REM sleep are not yet. What do you think about those that say everyone over X age or everyone meeting these criteria, which would normally not get a sleep study, should get a sleep study like a Wesper that does accurately track those things?
Oh, I think the sleep study is so important. I'm so happy you brought it up because I think it is the smoking gun. I think we probably have 30 to 40% of our population have issues around sympathetic tone, apnea, central apnea, which is that whole, the HRV getting stuck, right? It's funny. I'm wearing 3 devices right now, so I'm using an ultra human ring.
Yep.
I got an Apple Watch on, and then I use a Morpheus strap. And it's interesting because this is in between this and the strap for HRV. So I don't actually find that the ring that I'm wearing is as accurate as a actual strap for
Yeah.
HRV. And I don't feel like the Apple Watch does HRV well at all because it's interesting. A 30 HRV here, a 45 HRV here. This morning on my Morpheus strap, as soon as I woke up, a 72 HRV. So for at 64, pretty happy with a 72 HRV. And so I still think we've got a lot of room to improve on wearable data. That's my biggest concern. So I really agree with you on the more accurate picture you can get, the better. And the sleep study, I think, is like spot on, man.
Well, thank you. Glad to hear. I know we've gone over a lot of things, but I did have one thing that I wanted to get to when we still had time.
Sure.
We've messaged back and forth a bit about liposomal delivery and how much it could be shaken, temperature, this and that. Um, can you give a summary of one, just basics of what liposomal delivery is, maybe how it's different than micelles or microactive things, and then what they can take away from, like, do they need something that's liposomal, et cetera?
Sure. So, I mean, something that's just micronized may or may not absorb better. It depends on the type of compound it is. So, the more a compound is friable to the digestive tract, meaning it can be broken down, or the more it can't be broken down at all, called a class 4 compound, the more you want to think of innovation or technology that would allow for the delivery of that compound. Peptides, for example, very friable in the digestive tract, so very difficult to deliver peptides just by putting them in a capsule and taking them, right? Um, liposomes. So liposomes wrap lipids. So a liposome basically suspends the ionizing forces that keep things apart and unable to solubilize. It suspends that repulsion and allows things to basically be absorbed through a lipid wrap. So it allows you to wrap this lipid around a compound. The problem with liquid, and this is, you can look it up, this is like NIH papers, FDA papers, liquid liposomes tend to agglomerate. So they stay very small particles in the beginning, but if you read about them, they congeal, or they what's called agglomerate. So the electrostatic forces, instead of being suspended, and now they're kind of separated, keeping these small particles small, they start to go, uh-oh, we kind of are a magnet again, and they start connecting again and creating big molecules. So you go from under 100 nanometers to 3,000 nanometers plus, and now it's no longer absorbable. And that's just something that the FDA has shown.
Do exosomes also do this? Because I've heard from different exosome companies, 5 minutes after reconstitution, 7 days after reconstitution, 30 days after reconstitution, long shelf life, short shelf life.
Yeah, I think what you have to do is ask them for proof of their bioavailability. I know, and full disclosure, when I was developing synapsin, it was originally a nasal spray because you couldn't use it in a tablet form because it would just take too big a dose to get any beneficial effect. And the stuff, the compound is super expensive. crazy expensive. You can be a drug dealer for how much that stuff costs. I mean, and so we used a nasal spray, but that meant it had to be a prescription only because you don't eat through your nose, so it could not be a dietary supplement. When we discovered the liposome tablet technology, where you can suspend a 70 to 120 nanometer particle in a solid state liposome and then show under electron microscopy after 2 years, those particles are still small, that got me excited. And so we applied that solid state technology because it had worldwide patent pending on all drugs and all nutrients, because it was originally developed for opioids and cancer drugs, because you could deliver a smaller dose without approaching the LD50. You're not getting that lethal dose, right? But you're getting an effective dose then because you get enhanced absorption. So yeah, so for me, I'm really excited about what we've been doing with solid state liposomes because of the efficacy of electron microscopy, fluoroscopy showing that small particle maintenance after a period of time. And that means it's going to get across the blood-brain barrier. And that means it's going to absorb. So things like peptides or molecules that are hard to get across now get across. And so pretty excited about that. And we're also doing research on different weighted lipids topically that goes straight through into the deeper tissues to absorb. So, differing molecular weight lipids that will carry a vehicle through the skin. So I'm always tinkering with something, it's fun.
Yeah, I love that you're on the cutting edge of delivery mechanisms. We certainly need more scientists and scientifically minded individuals to keep pushing this forward. One thing that I've considered over the years is the concept of oral lymphatically absorbed testosterone, because as you probably know, but you're probably extremely familiar with anything compounding pharmacy related. Compounding pharmacies have had oral lymphatically absorbed testosterone for a long time, and now there is multiple FDA-approved brand name oral testosterones, but it responds a little bit differently than you may expect in labs. A lot of times it drops SHBG almost more like you would expect with that first pass effect, even though when you ask the MSLs, and for those who don't know, MSLs are basically the scientists that work for these companies, then
Yeah.
it's well more than 99% lymphatically absorbed if you take it with a fatty meal. Am I the only one that's noting that phenomenon?
Man, you're right on top of it. I mean, I'm very familiar with the recent oral testosterones that have come out that are phospholipid based. And it's interesting. We've actually played with that with the liposome tableting technology. I think the difference is what we've seen, and very limited, not to the extent of an FDA-approved drug, but what we've seen is that you can get by if you get true lymphatic absorption and you have the particle size down. We can get at physiologic dosing. So, 7.5 to 12 milligrams a day gives you a worthy testosterone in males. And I think I agree with you that they're not recognizing, at least just taking it. I'll give you a good example. I had one person that, oh no, it doesn't convert to DHT much because of the absorption. And I went, okay. So I gave it to someone and their prostate kind of blew up like a, basketball within 2 weeks, through our clinics. And it was, all right, well, there's a little bit more to this, as we all know, with what gets proved on it, and approved. There's always side effects and always changes in it. And so I agree with you that lymphatic absorption, it's another next generation of targeting.
Certainly. I love that outlook. I think that'll be a good place to end for today. There's a lot more that I would like to ask you, but I guess we're approaching the arbitrary limit of time. For those wondering, I guess both from the medical education standpoint, is there someone that can continue to seek you as a resource? And then also from the media standpoint, where are you based out of and such?
So media, Instagram's just the real Jim Lavalle. You can go to jimlavalle.com. If people are interested in really an organized education process, metaboliccode.com, which is where they could get trained up, utilize the algorithm system that we have. And look, anytime you want to have me back. This was just a blast to be able to talk to you. I rarely get somebody that's you're just up on it. It's that amazing.
Thank you. My pleasure. And yeah, honored to have you on. So thank you for joining us today. And thank you to all those listeners for their time. Please put any comments, nice, medium, or mean below. It helps the algorithm regardless of what they are, whether you like peptides or don't. But yeah, as always, may God bless everyone with health and happiness.